Good morning. Today we're going to be talking about pulmonary tuberculosis. As we explore the topic of pulmonary TB, it's important to recognize that this disease remains to be a global epidemic. In 2022, TB was the world's second leading cause of death from a single infectious agent after COVID-19, with approximately 1.3 million deaths. Each year, over 10 million individuals are diagnosed with tuberculosis that severely impacts public health. Notably, certain countries are disproportionately responsible for roughly two-thirds of all TB cases. Today, our focus is on drug-susceptible, active tuberculosis, and latent tuberculosis. While not covered in this lecture, we need to recognize that drug-resistant strains such as MDR-TB and XDR-TB present additional challenges in treatment efforts. And lastly, tuberculosis is not limited in the lungs and can also disseminate and affect various organ systems. The goal for latent TB testing is to identify those who will benefit from prophylactic treatment. The tuberculin skin test, or the IgRA quantiferin test, does not differentiate between latent and active TB infection. Patients with latent tuberculosis infection, or LTBI, have a 4 to 6% lifetime risk of developing active TB, with approximately half of these cases occurring following a recent exposure. Studies provide high-quality evidence that treatment of LTBI reduces the incidence of active TB among persons at higher risk for progression. And this figure here is just for your information. This figure highlights the diagnostic testing that we use for both latent tuberculosis and active tuberculosis. And for lecture objectives, by the end of this lecture, you should be able to describe the pharmacokinetic and pharmacodynamic properties of antimycobacterial agents, including mechanism of action, adverse drug effects, and monitoring parameters. Number 2, recognize patient populations with latent tuberculosis infection who are at increased risk of developing active TB. Number 3, identify the clinical presentation of persons with active pulmonary tuberculosis. Number 4, describe the pathophysiology of latent and active pulmonary tuberculosis. And number 5, given a patient case, develop an appropriate antimicrobial regimen for the treatment of active pulmonary tuberculosis. Number 6, given the patient case, develop an appropriate antimicrobial regimen for the treatment of latent tuberculosis infection. And number 7, when given a patient case, manage clinically relevant drug-drug interactions between patients' medications and the antimycobacterial agents. The primary pathogen of concern in pulmonary tuberculosis is Mycobacterium tuberculosis, or MTB for short. The pathogen spreads primarily through the inhalation of respiratory droplets from infected persons when they cough, sneeze, and speak. When the pathogen reaches the alveoli, it is then engulfed by alveolar macrophages as part of the person's innate immune system. Then, cell-mediated immunity gets involved and recruits more immune cells to form a mature granuloma. When the pathogen is contained in the granuloma, it can die off or stay dormant, leading to latent TB infection. However, a dormant pathogen can reactivate and escape the granuloma and further proliferate, leading to active TB disease. It is worth noting that over time, a granuloma can lead to pulmonary tissue necrosis and form cavitary lesions that can be seen in diagnostic imaging. Here you can take the time to pause the video and analyze the diagram to aid your understanding of the pathophysiology of pulmonary tuberculosis. As mentioned in the previous slide, we know that latent tuberculosis can develop into active TB. Given that TB has the potential to be fatal, the goal of testing for LTBI is to identify persons who will benefit from prophylactic treatment. The 2016 IDSA TB diagnosis guidelines tell us that select groups of people are at a higher risk of developing active TB, and it is suggested that persons identified as high risk have reduced ability to contain the disease in comparison to persons at low risk. Persons at high risk include children aged less than 5, persons with HIV, persons undergoing immunosuppressive therapies, persons with abnormal chest X-ray consistent with prior TB infection, and silicosis. If progressed into active TB, they can have more severe disease presentation and greater mortality. The prophylactic treatment options for latent tuberculosis infection will be discussed at a later slide. So what is the clinical presentation of pulmonary tuberculosis? For active tuberculosis, unintentional weight loss without changes in diet or exercise routine. Next, we will discuss the clinical presentation of pulmonary tuberculosis. Given that pulmonary tuberculosis is a pulmonary infection, it can present with some nonspecific symptoms like having a nonproductive or productive cough. However, some symptoms that raises our clinical suspicion of active tuberculosis include hemoptysis, unexplained weight loss without change in diet and exercise, and night sweats. Other nonspecific symptoms include fever, chest pain, loss of appetite, and fatigue. In contrast, individuals with latent tuberculosis are asymptomatic, which makes screening vital as discussed previously. Diagnostically speaking, latent tuberculosis is confirmed with a positive TST or IGRA, and they will present with a normal chest x-ray and would have a negative acid-fast bacillus smear or culture. Active TB shows similar TST or IGRA results, but with an abnormal chest x-ray and positive AFB or culture results. Moving forward, we are now going to discuss the recommended treatment options for drug-susceptible active tuberculosis. When starting treatment, it is important to be aware of the goal of treatment, which includes rapidly reducing microbial burden to decrease severity, prevent mortality, fully eradicate bacteria to achieve a durable cure and hopefully prevent relapse, and lastly, to prevent development of drug-resistant TB. Active TB is comprised of two different phases. The duration of treatment for the intensive phase is 8 weeks or 2 months, and the continuation phase is 18 weeks or about 4.5 months. The intensive phase of treatment consists of 4 drugs: isoniazid, rifampin, pyrazinamide, and ethambutol. And you may hear other clinicians refer to this treatment as RIPE. There are 4 drugs in the beginning of treatment because of the current proportion of new tuberculosis cases worldwide caused by organisms that are resistant to isoniazid. The 2016 IDSA guidelines suggest that ethambutol can be discontinued during the intensive phase if culture insensitivity result shows susceptibility to both isoniazid and rifampin. After the intensive phase, the continuation phase follows, where both rifampin and isoniazid is continued for 18 more weeks. This table provides comprehensive information about the preferred dosing regimens when treating drug-susceptible TB. Regimen 1 is preferred and provides the greatest effectiveness when compared to the other 3. In both intensive and continuation phase, it is recommended to take the medication once daily every week. Taking the medications 5 days per week provides similar efficacy. However, this is only preferred when the patient can be directly observed by a healthcare professional. This concept is also referred to as direct observed therapy. If the patient is tolerating the medication poorly, then a 3 times weekly regimen can be considered, only if the patient is HIV negative without any evidence of cavitary lesions. However, this regimen is only recommended if direct observation is feasible. Overall, regardless of administration regimen, intensive phase must be taken for 8 weeks and continuation phase must be taken for 18 weeks. Next, we will discuss each of the medications used during active TB treatment. Rifampin belongs to the rifamycin class of antibiotics, and other examples of rifamycins include rifapentine and rifabutin. We will discuss rifapentine again when we move on to the treatment options for latent TB. Rifampin works by inhibiting bacterial RNA polymerase, leading to downstream inhibition of protein synthesis. Proteins are functional units of any organism, therefore, inhibiting protein formation leads to bacterial death. Monitoring parameters that you should be mindful of include liver function tests and complete blood counts, or CBCs. This is important to monitor as we will discuss potential side effects of rifampin in the next slide. The adverse effects and toxicities of rifampin include hepatotoxicity, which explains the necessity of monitoring for LFTs as mentioned previously. In addition, hematologic effects can manifest, including hemolytic anemia, so people could show up with bruises for that one, hemorrhaging, leukopenia, and thrombocytopenia. This explains the need to monitor for CBCs. Other adverse effects include pulmonary toxicity, hypersensitivity reactions, including rashes, DRESS, SJS, or TEN. Interestingly, rifampin can cause body fluids to turn into a reddish-orange color. GI side effects can include nausea, vomiting, cramps, and discomfort, and flatulence. The next agent is isoniazid. This antimycobacterial acts by inhibiting the synthesis of mycolic acids, which is a component of the mycobacterial cell wall. This makes it specific to Mycobacterium. Hepatitis is a risk with isoniazid treatment, hence it is a black box warning and LFTs should be monitored. Continuing from in addition to hepatotoxicity, peripheral neuropathy is another known adverse effect of isoniazid. Persons who are at increased risk of peripheral neuropathy include persons with diabetes, CKD, history of alcoholism, the elderly, pregnant women, and those who are breastfeeding. To prevent isoniazid-induced peripheral neuropathy, pyridoxine, also known as vitamin B6, is given to those at high risk of developing peripheral neuropathy. Central nervous system manifestations are also possible, and they can present as seizures, optic neuritis, and encephalopathy. The next anti-tubercular agent is pyrazinamide. This agent works by acidifying the mycobacterial cytoplasm that affects various bacterial enzymes that are necessary for growth and multiplication. The adverse effects associated with pyrazinamide include dermatologic effects that can manifest as acne, rash, and photosensitivity. Hyperuricemia is another potential side effect. This is an important consideration, especially among people with history of gout. Therefore, uric acid monitoring should be considered. Hepatotoxicity has also been reported with the use of pyrazinamide. Therefore, LFT monitoring can be considered. GI effects include nausea and vomiting. And this medication should be renally adjusted as its metabolites can accumulate among persons with renal insufficiency. The final agent, ethambutol, works by inhibiting an enzyme that's necessary for the synthesis of cell wall components. Without this, Mycobacterium cannot proceed with cell division. In terms of adverse effects, the biggest concern associated with ethambutol is the risk of optic neuritis or inflammation of the optic nerve. This leads to visual disturbances. Therefore, persons receiving ethambutol requires a baseline and monthly visual and color discrimination test. Dermatologic side effects are also associated with ethambutol, including but not limited to rashes and dermatitis. Similar to pyrazinamide, it is also recommended to renally adjust for ethambutol. Here you can pause the video to look at the monitoring parameters that the 2016 IDSA guidelines recommend when treating active TB. This diagram includes additional monitoring parameters to assess the overall clinical progression of the patient and other important baseline parameters such as comorbidities. Moving on to DDIs, rifamycins and isoniazid are known for DDIs, and rifamycins moving on to drug-drug interactions. Rifamycin and isoniazid are known for drug-drug interactions. Rifamycins are CYP3A4 inducers, where isoniazid is a CYP3A4 inhibitor. On the right, you will see a list of some medications that are metabolized through CYP3A4. However, there are plenty other medications that can potentially interact with rifamycins and isoniazid. You should be able to assess how either induction or inhibition will affect safety and efficacy of these medications. Lastly, here are a few general treatment considerations when treating for active TB, and provides a brief summary of anti-TB medication side effects. As TB medications are known for causing GI upset, it may be useful to counsel patients to take it with a light snack. However, food may impact bioavailability of the medication, and IDSA guidelines suggest that using antacids will have less of an impact on bioavailability on anti-TB medications. As mentioned when discussing each individual medications, rash is a common adverse drug reaction across the board, and therefore there is an important education point to provide to patients. And lastly, we are going to discuss latent TB treatment options. As opposed to active TB, latent TB treatment can be as short as 3 months as opposed to 6 months. However, some latent TB treatment options can last up to 9 months, but they are not the preferred option. The preferred regimen of weekly isoniazid and rifapentine for 3 months is beneficial, especially among persons who struggle with adherence and has lower uh, chances for side effects given the limited exposure to the medications. In addition, this regimen has been studied to be effective in persons with HIV. This is an important concept to understand because, as previously mentioned, persons with HIV are at increased risk of developing active TB. It is important to be cautious of what regimen you recommend, since some of these uh, recommended regimens have not been studied among persons with HIV. And that is the end of my presentation. Thank you very much for listening.